It's my distinct privilege and honor to introduce our three panelists. They've been partners of ours for a while in our Fair Cost Health Plan and Friends of Mitigate Partners. We thought it was to give y'all a unique perspective into this COVID test mandate and so forth. We thought it would be a great to share three perspectives. So from the legal perspective, we got Lorie L, ERISA attorney and partner at the Fisher and Phillips office in Atlanta, providing the PBM perspective. And it's not really a PBM. I'll let her speak to that. We don't have program bilking millions here. Catherine Mackey, Senior Director of Strategic Implementations from Ventegra. And then lastly, provide a stop loss perspective and the claims funding liability perspective will be Julie Bobak, Senior Vice President, Accident Health for Intact Insurance Specialty Solutions. And without further ado, Lorie, take it away.
Terrific. Thank you, Carl. And thanks for all of you for joining. I'm going to take on the legal compliance part of this. And I'm going to apologize. I'm not seeming to be able to control my slides. Let's see. Carl, I am not able to move through.
Lorie?
Yes.
First, share your screen. Or if it's better, I can move through your slides. I believe it's my screen that's still being shared anyway.
Okay, I apologize. I thought we were working from these slides. So, well, first thing, while we're waiting on me to pull this up, I did want to just start out by saying we're obviously today talking about the group health plan test mandate for covering the cost of the test as opposed to the OSHA ETS and the Biden vaccine or test mandate. And, I'm sure that all of you have been following that very closely and would know by now that the Supreme Court determined that it had very little chance of ultimately being approved. And so the Supreme Court did recently strike down the court decision that let that move forward. So the timing of this group health plan test coverage mandate was very, very close to the same, test or vaccine mandate. And, potentially was, one of the things that was part of the overall effort to make testing more accessible to the employees that maybe weren't vaccinated. But we, that was, struck down for all but healthcare workers. So it still is out there. And the other thing I just wanted to say about that is, that OSHA, even though that is not part of their ETS, that they weren't allowed to move forward with it, OSHA has sort of signaled that, they will still be auditing employers. And, that testing and vaccine mandates, that may be something that they might look at on an OSHA audit. So even though the mandate itself went away, that's something that Fisher Phillips has been monitoring closely. And I would encourage you to go onto our website in order to, get more information. We've been, putting out some great information. So, okay, so back to my technical difficulties. Is everyone, let's see.
I've given you the ability to share your screen, but if you would rather me pull those slides back up, I'm happy to.
I am happy to share my screen. I'm just trying to make sure that it's going to show for you. It's just, I don't know why I'm not having very good success here.
No problem. I can help.
Yes, I had it. I'm just trying to make sure that it's going to show for you. Okay.
Lori, try to pick your other screen to share. Select the one that the presentation's on.
I did.
Hmm.
I'm trying again. Unless my screens are not. Oh, I'm so sorry. Okay, Christy, can you just control, because it's just not it's not working.
Yes, ma'am.
Thank you.
Hold tight.
So just as a little bit of background, the original Families First Coronavirus Relief Act that was adopted on March 18th, 2020, that act required free COVID testing beginning as of March 18th, 2020. And that free testing obligation is to last for the entire public health emergency. So everyone's plan should already be covering COVID tests for free. That should be no cost sharing, no prior authorization, no medical management techniques. And, so that's been something that's already in the law. And then shortly after the FFCRA, the CARES Act was adopted, and under the CARES Act, it set reimbursement rates, how to determine what the plan's going to pay for these tests that are now free to employees and participants in your plans. So if there is a negotiated rate with a network provider, for example, for the cost of that test, under the CARES Act, the plan is required to pay that negotiated rate. So you can set the price with your network providers. If you don't have a network specifically, or no negotiated rate is set, the Act requires all providers of those tests to publicly post on a website what they charge for the COVID test. And plans and issuers, insurance companies are required to pay the cost that is posted on the website. Every provider is required to do that posting or face potential penalties. Okay, next slide. Okay, Christy, can you move forward?
Yes, I'm trying. I keep pressing the same button I was pressing all along.
Oh, good. I'm glad I'm not the only one with having technical difficulties. Well, I'll just kind of keep talking. So these are the two basic laws that we have that were enacted by Congress. And then subsequently, Department of Labor, Internal Revenue Service, and Department of Health and Human Services have issued a series of FAQs that interpret these laws and have provided us with additional rules and parameters. And what I know we're all waiting to hear about is the FAQ 51, which is what was just issued on January 10th regarding the at-home test. And the reason I'm giving you all this background is that it's important to know because these rules are still in place. So we're kind of building, on what is already in place, and then we'll talk about what's new, because in the end, you have to comply with both of these. So the first FAQ that we want to talk about is Part 43, and it provided that the free COVID tests included at-home tests. So you've seen a lot of headlines that say, in the last week or so, that at-home tests must be covered. Actually, at-home tests have been required to be covered since June of 2020. It was just that at that time, the FDA had not approved any and they weren't available. But free COVID at-home tests, if they were FDA approved, including under an emergency use authorization, have been required to be covered if they were ordered by an attending healthcare provider. The other restrictions are that they must be medically appropriate, and the test is not for any kind of employment screening or public health surveillance purposes. So the test had to be for medical diagnosis, not because someone wanted to travel or needed a clean COVID negative test to return to work. Under the FFCRA and the CARES Act, there's no limit on tests that are covered. So even still today, if you get a test ordered by your doctor, that has to be provided regardless of any other limits that might be out there. So let's switch to the next slide.
I'm so sorry to have to keep doing this. I don't understand why these things are happening. This is not, normal for me either, guys. So,
no, I had trouble on that screen sharing. It was just stuck. It wouldn't let me. Anyway.
Christy, you want me to try, Christy?
I think
we're on it. So the Biden-Harris expansion that just happened is under another of the ACA FAQs. This one was part 51. It was issued January 10th and had an effective date of January 15th. And what this most recent FAQ did is significantly, it removed the requirement that a healthcare provider order the test. So this means anyone can buy a test without a doctor's order or even without having symptoms. But the limit is 8 tests per covered person per month. So everyone who wants to buy a test can do that. They don't have to be sick at the time they buy the test. They're allowed to buy, a family of 4 can buy 32 tests at once. And if they then get a doctor's order to take a COVID test and do an at-home test, they can have more tests. So the 8 per month is not an absolute limit. It's only a limit for those purchasing tests under this new FAQ Part 51 without a doctor's order. So some more clarification that the Department of Labor, Health and Human Services, and IRS provided is, again, these tests are not allowed to be purchased for employment purposes or travel purposes. They are required to be purchased for personal use because of illness and potential COVID diagnosis. The way the test was designed was intended to make sure, for health equity purposes, individuals could obtain the test free without having to submit out-of-pocket expenses and then get reimbursed. So the FAQ 51 and the administration's expansion significantly incentivizes making the test free at the point of sale. And so they've created a safe harbor, kind of a carrot and stick here. So the safe harbor is that if under your plan, an employee can walk into a pharmacy or store, obtain a test for free, or go to a direct mail pharmacy that you've made available and get it for free, then you are able to limit the amount of reimbursement for tests purchased anywhere else or out of network to $12 per test without regard to what the participant might have paid for those tests. So the ability to limit the cost to $12 a test depends on your ability to make the test free at the point of sale. Now, there is a tricky part of this, is that the point of sale, to meet the safe harbor, has to provide adequate access. Now, what this means when there are no tests on the shelf at your available pharmacy or everyone's out of stock online, sort of begs the question, what will happen to your safe harbor protection and status? Because if you can't provide reasonable access via the free method, that may just put you outside of the safe harbor. So there's a little bit that remains to be seen on what kind of ultimate financial impact this will have, because obviously as tests get more scarce, prices go up. And, there is certainly concern among everyone who's involved on ultimately where this will go. And we have excellent speakers coming after me that hopefully are more technically savvy to to address those kinds of issues. So some other issues I wanted to address is, I think, there was some recognition that if employees and participants and dependents can go out and buy these tests without symptoms, without a doctor's order, up to the maximum, there could be temptations for misuse, reselling the tests on the black market themselves, or impermissibly using them for employment purposes, for screening, for travel, for other things. The FAQ does allow employers to address fraud and abuse directly. And many of the forms I've seen so far include attestations by the, for a test that's purchased outside of the safe harbor, outside of the free point of sale, when you're submitting a claim, or you're saying that it is not being used for anything other than diagnosis. I haven't figured out yet how, if you just go and purchase and at a retail pharmacy and you're buying it, maybe they're going to ask you to make that attestation there. I'm not quite, this is all still developing, but employers certainly can control their own communications to make sure that in the advertisement of this new plan feature, that you make it clear that what the purpose of the test is for, and how it may be a violation of employment terms to falsify the claim and stockpile tests and use them for other purposes. So, obviously want to discuss specific language with your employment lawyer, but you can indicate that, falsifying claims, and this is true for any claim under your medical plan, if you falsify a claim, that's an employment offense that's punishable up to termination of employment. So you can also, for claims, require different proof, UPC labels, receipts, things like that. So I think I'm sorry, there's a question popping up that I think we're going to save questions for the end, but we will definitely get to you. So the other thing I did want to mention before we go is that in those employee communications, that the government is making available 4 free tests per household. So we're encouraging employers to kind of get ahead and, let employees know about the government program, and in those communications. So that may ward off some of the initial purchase under your plan. So for next steps, for employers, you'll want to contact, your providers and confirm how, or your vendors, and confirm how your claims will process, pharmacy or medical. And, that's important because it's an 8-test limit. You want to make sure that it's, that's being enforced to 8 if you have both your pharmacy benefit manager doing the, adjudicating the claims for the test, you might get 8 there, but if you have medical doing it as well, you might be ending up with 16. So coordination there is key. And also, making sure that you have a plan for making the safe harbor available. For employers who are listening, we've seen a lot of opt-outs. So that can be a little bit confusing. It's not that anyone is eligible to opt out of this as the law, but you could opt out of limiting the test to $12 a test. You can pay full cost for whatever it is that your employees pay. I'm not sure why you'd want to do that, but you could. And, maybe some employers do want to make the tests more available and fully subsidized. Other things you want to make sure you're doing, amend your plan documents. This is something that you will definitely want to get in there. And we'll talk about that, I think, a little bit later too. And we've already talked about employee communications, but these are some of the key things that you should be thinking about and doing right now to get yourself in place for a requirement that went in effect already January 15th, but was so fast. I think probably it was already effective before many people even heard of it. So I'm going to stop there and turn it over. Again, we'll do questions later, but I'm going to turn it over to Catherine.
All right.
Catherine, you take over.
Okay, you got it, Carl. Let me do the screen sharing attempt tango. So hold on just a second.
You should be able to just take over a new share.
Oh, I got it. All right, you should see Carl's face, everybody. Right?
What the heck is that up there?
All right.
Get that off quick.
Well, I think you'll all agree, what a great presentation, Lorie, and so packed full of information. Tough to follow. Give me one quick second. I got a dog that doesn't like this, so I'm going to shut my office door. And that would be the thing that was behind the office door coming to a quick crash. Thank you, and sorry about that, everybody. Very loud. I can tell you that there's just no time in history like this for us in the pharmacy industry as a whole. And there's nothing like the government to hijack all of our time in the last 2 weeks, trying to figure out a scramble in interpreting the law. And Lorie just so eloquently laid that out. So I'm not really happy about following her, but here I am. And I thank you, Carl, for bringing a PBM perspective. And I'm going to say PBM, but like Carl had mentioned, Ventegra. And that is who I am with. I'm Catherine Mackey with Ventegra, and we are a California benefit corporation, and we claim ourselves as an MBM, a medical benefit manager, that provides the pharmacy services administration that you typically see in a PBM. With that, I've had 35 years experience. Just a little background on me, 35 years of experience in pharmacy, from starting as a pharmacy tech all the way through college, and now here I am in this career with Ventegra. And Ventegra was formed because we were all in the old PBM industry and wanted to do something different. So as we kind of walk through this, just know that my interpretation, our company interpretation, is slightly different than what you might have in your engagement with your current PBM or your current TPA. I obviously cannot speak for all of those other entities, but I can provide some perspective on what we see out in the retail sector, because we have relationships with retail pharmacies, what we know from other competitors, what we've heard in the industry so far, and then lastly, what we do and what we know we have taken action on, which I was very excited because some of those clients, I'm not sure some are on the phone, but Carl and Ventegra we're really good partners with Mitigate Partners, and are processing prescriptions for some of the clients that are represented here today. So with that, it's not advancing for me either. Okay, hold on just a second.
You won't.
Okay, no, I got it. No, got it. So what is it? And as Lorie had went through, it's a mandate for insurance companies and group health plans to require the cost of the FDA approved, and I'll stop there. It's FDA approved under the emergency use authorization for the at-home over-the-counter COVID-19 antigen tests. It's got to be free. What a burden to employers. Got to be free to the member. Mandate released on Monday, January 10th. So they didn't really give us much time to figure this out, right? Effective January 15th. So we scrambled as an industry to figure out, how do we actually make this happen? How do we make sure that your employees and members nationwide are able to meet the expectation that the government is advertising, very well advertising? And what are the details of that? So insurers, as Lorie said, can cap the reimbursement at $12. You must have an available access network. And this is the most interesting thing that has come up in the last week as well, is that available access is also being defined as adequate access, as Lorie said. And adequate access is such a vague term. And I'm sure in Lorie's expertise as a lawyer, she knows, adequate access is wide open to interpretation. We at Ventegra, we took the literal interpretation, and we opened this up to our entire Ventegra network. Some providers opted to not participate, but we have 55,000 pharmacies participating in an available access network. Simply because what we didn't want to have happen was to have our employers not have adequate access from the beginning. We just don't believe that route is the best way to go. So we didn't necessarily know, as Lorie kind of put out there in her presentation, what that would mean to employers in the long run if we didn't provide that adequate access. So we didn't want to be seen as a barrier to the mandates under the ACA Act that could potentially have a downstream effect to employers. There are 2 points of access allowed. Point of sale, which means it transmits from the pharmacy to the PBM, and the PBM adjudicates that claim and sends it back to the pharmacy, and the pharmacist says, okay, this is paid for, you can have this now. Or direct member reimbursement. And this is what we see happening quite extensively at the current moment. Most pharmacies are not agreeing to fill these prescriptions. And there's many, many, many reasons surrounding that. Some of them are legal restrictions at the pharmacy, state law restrictions that prohibit them from transmitting information without a legal prescription. And as we know, at the current moment, we aren't seeing physicians write prescriptions for at-home tests. We did have, that being said, we have one provider did do it, but the majority of your providers out there, don't have the bandwidth to do this, as we all know, in getting our prescriptions and things filled from the doctors. They don't have the bandwidth to support that. So what we're seeing happen is members walking up to the pharmacy. The pharmacist is selling the test at their cash price and informing the members that in order to get this covered by your plan, you will need to submit for direct reimbursement. Ventegra took the stance of, we understand that pharmacists might not do that. It's up to their discretion. We don't have a strong control method for that. And then Ventegra, for our plans, unless our employers opted out, we would be allowing those direct member reimbursements to happen at Ventegra at no cost to our clients, which is a nice thing, because we actually view this as, a state of emergency in the a health emergency in the country. So no need in profiting off of that in our model. And what are the details? Max 8 tests per month, per member, per month. And it's controlled, all that maxed 8 edits for us is controlled via the point of sale service. And what does that mean? So right now you have the option for the pharmacy environment, the PBM side, or your TPA, your medical side. So we have some clients that are opting to have everything covered under the medical side. We have viewed that as a little bit risky, because on the medical side, if you're doing that, you can't really cap it at the $12 quite as effectively as you can if it's covered on the pharmacy side. And a combined effort of those is not actually achievable in time and space today, in that medical data is retrospective. So not real time, and pharmacy data is real time. So the accrual, if it were to be a combined, is not really an effective way of making sure that 8 test mandate is calculated properly. So the other thing about this is, and this is one of the most frequent questions we get, is, well, when is this going to end? How do we predict how long this $12, per member per month at 8 tests? So, quick math, $96 per member per month. How long is that going to last? Well, as Lorie was pointing out, it's mandated by the ACA Act, and it's tied to the federal emergency requirement that says all of this kind of acts within that bubble. And once the government says that is done, that's when we anticipate in our reading that this requirement will end. So right now, no indication of that actually going away. So what did we do? Like I said, we allowed our self-insured employers to determine the best path for their model. What we didn't do was be a barrier to that access. So we know that access is a strong issue, and we know that there could be fines that not Ventegra would incur, but our employers. So we acted swiftly to allow employers to make the best determination for their model, and we're quickly on the phones with every one of our clients to determine what was the best solution for their model, and fielded lots of questions on as they themselves were trying to peel back this onion. We contacted Pharmacy Network to establish a network of providers for real-time adjudication. So because of our unique situation in the industry, we had almost every retailer on the phone within days, understanding, well, what are they thinking? Do they have inventory? And would they agree to process through our network with no additional fees? So we took a very harsh stance and said, we don't believe that employers should have to incur additional dispensing costs for this. We want this to be sent through under the emergency use protocol, and really believed that pharmacies should step up and do the right thing and just be paid for what they're purchasing the tests at. So we took a stance for that, and as a result, we have 55,000 pharmacies in our network that agreed with us. There are a couple that wanted to be a little bit more greedy than we were willing to allow. We implemented on Saturday morning access levels as determined by the clients, and some clients opted out. We have some integrated health systems in our network that chose to administer the tests on site. So their adequate access determination was deemed within their own model. And like I said, again, there's no indication of the requirement deadline. So what's happening now? And this is the golden question, because it seems to be ever fluctuating. We have a team of people that meet on this every day, including our own legal team, that helps us to navigate the ever fluxing landscape of this. Okay, so clients that chose to have testing run through their pharmacy benefit, those claims are processing. So that's great. What I can tell you is while we thought there might be an influx of people running to the pharmacy, they may have ran to the pharmacy, but the pharmacy said, we don't have the tests. We can't transmit these online. So we actually are seeing very low volume. I ran a report before this presentation, and out of the 1.9 million lives that Ventegra represents, we saw 28 submissions across that entire book of business. So super low real-time submissions. We have not received any DMRs yet, direct member reimbursements yet to date. But we do anticipate those will start coming in. What is our hope in that space? Our hope is that people understand that nothing is really free, and that by them submitting DMRs, we hope that they recognize that potentially has a long-term downstream effect on the overall cost of healthcare. So we hope that we see clients that are taking advantage of the 4 free tests that are provided by the government. And what better way? It's so simple. If you haven't done it, you log on. It's done through the United States Postal Service, which I was happy to see. United States Postal Service. really, it takes seconds to do. You put your name in, qualify your address, and you get 4 tests sent to your house per household. So super easy. So we're hoping that that does happen. And what challenges? And I think this is a big avenue for us to discuss, challenges. And the biggest one that we think is out there is balancing access with client costs. There is no inventory. It's very little. If you happen to come across some, pharmacies themselves are limiting to 2 tests per person. And they're asking you to be honest about that per day and not come back and do these and get these out on the black market and all the many things that could be happening. So we're trying to balance access with client costs, because we definitely know that if we were in your shoes, we would not exactly know how to be handling this situation. Some of the challenges out there. Our state requirements inhibit access. There are many states that are not allowing the pharmacies without penalty by law to be able to submit the OTC tests without a valid prescription or a valid prescriber identification numbers, which is called an MPI. Without those elements in, some states actually can't even meet the mandate that's put out by the federal law. So what do those states do? So what we've heard is their only real option is to let the member know, we can sell it to you, we cannot bill it to your employer by law, but you can do a direct member reimbursement. So that's a challenge in that it's creating this cog of a wheel for the HR departments for some employers, because while the news says one thing, it's 5 o'clock news, 6 o'clock news, whatever you're watching or how you're getting your news, says go into the pharmacy and get those prescriptions. Well, it doesn't really talk about some of the channel access issues that are out there. And we are hearing this as being a real pain point for our employers, and especially at the HR, because they really don't know HR departments. And then some of you may be in HR for your company. You don't know how to interpret this. So hopefully you have good guidance from your PBM that is helping you navigate that. But certainly a challenge, and we are empathetic at our company for that. Pharmacy submission requirements that create the challenges. That's kind of one that I was talking about before. Another thing is that it's a package size issue out in the industry. So let me talk about what a package size issue means. So 8 tests per member per month. Well, and some of you may have seen out there that some packages have 2 tests in them. Some packages have 5 tests in them. And this is what has made the online submission from PBMs a real nightmare to figure out. And that is simply because of the way in which pharmacies have to communicate to payers like us in real time. We were able, because of our commitment in the space that we're working in, we were able to be very nimble in this situation and figure the solution out very quickly, and came with a strong solution that doesn't allow barrier to access, communicated with our providers, and gave them guidance on how to submit that prescription to us should a member be bringing a box that has 5 tests in it. Because 5 was typically viewed as 1. So while we were going to pay $12 per test, if the pharmacy only submitted 1 and the cost for that was $80, they would have only gotten paid $12. So challenges on our side to figure out how to also be fair to our pharmacy partners in this space. And as I talked about before, the pharmacy providers are electing not to submit to PBMs without a written prescription. And we honestly think that they're doing that to a couple of things. They don't really have the staff. Their staff is tired, having to give inoculations pretty consistently and navigating the ever-changing landscape of being able to staff their own pharmacies during COVID, where they have their own team members getting COVID. So they're constantly understaffed. So we think there's a couple of things. One, if shareholders can't make money, There we see, major providers out there that are owned by PBMs choosing to do a different path. And those kind of create some barriers in that space. But really, what are the next steps out in the industry now? Managing the ever-changing landscape. This has, like I said before, hijacked pretty much everybody who works in this industry's time in navigating what's out there. I like what Lorie said, is that we hope that employers are encouraging your members to take advantage of the free test, simply because while we know that that program does not have enough to support and I say enough access in terms of tests to support what's really happening, and the sheer number of people living in the United States, not really enough access out there. So as we kind of move into this changing landscape, we'll all be 2 steps behind the government, unfortunately. We'll be managing the direct member reimbursements, and hopefully you'll see some, and if you haven't, I encourage you to work with your providers to make sure you're getting dashboards on your direct member reimbursements. Let's talk about this. Normally, direct member reimbursement is a very minuscule portion of the overall benefit. When I asked our internal team to calculate the number of direct reimbursements in a 5-year period that we received on the almost 2 million members, it was under 20. In 5 years, under 20 real direct reimbursements that we've received. So we don't have a much of a need to have a strong reporting avenue for our employers out there, because in the PBM space, everything adjudicates online. So I encourage you to work with your partners in that space to make sure you're getting a snapshot of understanding what that really looks like. And we're monitoring the claims. And like I said, we are seeing a very low uptick in this at the current moment. And communication is the key, right? So hopefully you're getting good communication out of your current PBM. I know Ventegra has taken a really great stance on this, and we're constantly communicating to all of our clients. And, like we say, the phone lines are open for all clients to ask us any questions that they need to support their membership. And the government website is releasing the free test, and that was yesterday. So that's exciting. And we should see those within 1 to 2 weeks. What 1 to 2 weeks does when we have a surging Omicron, not really sure. But that's it for my presentation. Thank you for allowing me to ramble on about what we see in the pharmacy benefit space. So thank you. And I will hand this over gladly.
Thank you, Catherine.
You're welcome.
See if I can get screen up now. Okay. Well, I'm Julie Bobak from Intact Accident and Health. We're an insurance company and we provide medical stop loss. I'm here to talk to you today about the stop loss perspective on this government mandate to cover over-the-counter tests for COVID-19. I told Carl that the real reason that I wanted to join this group was because he had 2 excellent speakers lined up and I really wanted to learn from them. But hopefully I can give you a couple of additional insights about the costs and so forth to think about. So I assume most employers are wondering what the potential cost impacts are to the plan. And I really have to kind of give a disclaimer here. We really don't know what the new requirements are going to cost to plans, because we don't know if there's going to be enough tests to meet the market demand, or if this is just going to further exacerbate the testing shortage that's already in place. In addition to just the basic costs of tests, factors that contribute to the cost include the fact that there's limited test supplies, limited access to suppliers. Initially, members won't understand the program. There is a workload involved in submitting documentation for reimbursement. And we don't know what the ongoing need for testing will be over time as the infection rate changes and goes up and down. But if we look at a maximum exposure where a plan is able to limit the cost of tests to $12 per test and 8 tests per member per 30 days, the result is about $3,000 per employee. And this is a composite employee, including those that are single and those that have family coverage. And that's about a 20 to 25% increase in claims for an average plan. That's a lot. We don't really think that the maximum exposure is what we're looking at here, but with all of these factors above, it's really difficult to come up with what an average expectation is. So if we look at maybe a low point of an average of about 2 tests per employee per month, that would actually increase plan costs just under 2% on average. So it's still a measurable amount. One of the Mitigate partners shared this Kaiser Health News article that just came out yesterday. 5 things you should know about so-called free at-home COVID tests. I think what it's interesting to point out of this article, which you can, there'll be a link to it in this presentation. Nobody's predicting that the insurance companies are just going to swallow these costs. As usual, they will most likely pass costs along to their customers. Well, there are ways that employers can try to manage costs of the plan. So we'll talk about some of that. Again, limit the number of the OTC tests to 8 per family member per 30-day period as the guidance allows, as the mandate allows. Offer a preferred arrangement so that with no out-of-pocket cost to members, and then tests obtained outside of that arrangement can be limited to cost not to exceed $12. But in addition, employers really should require reasonable documentation of proof of purchase and an attestation that the tests are purchased for a member covered under the plan. And I'll talk a little bit more about that in a minute. In addition, it's going to be important to provide education and consumer support to facilitate access to and effective use and prompt payment for over-the-counter tests. If you think about just before the holidays, we were hearing a lot of conversation from the administration about getting together, families getting together and so forth. And there were some recommendations out there from various sources that, you know, perhaps family members should all get tested before they get together for the holidays. Well, it's not unreasonable to think that members might think, well, you know, if they've got a big family birthday party coming up or an event, perhaps they should purchase a number of tests and make sure everybody gets tested before everybody gets together. Well, that's all well and good, but a particular employer only needs to pay for the tests for the people that are actually covered by their plan. They don't need to pay for tests for family members and friends that get invited to events and stuff. And members are not likely to understand this. They're not going to know this until it's all explained to them. So communication is really going to be important as well. Let's talk about what the impact on insurance costs should be. If given the range of a 2 to 25% increase in cost, that's a lot of uncertainty to the trend levels that carriers select at the time of renewal. However, I am projecting that self-funded employers with a track record of actively managing their plans should expect that carriers will push trend increases at renewal and be less likely to negotiate on getting that trend increase. Plans aren't going to, employers are going to see costs go up. This is really going to be more of an impact on aggregate factors than overall premiums. But I think that employers really need to expect that aggregate factors will adjust above what we have traditionally just thought of as medical trend. However, fully insured or insurance company managed plans are likely to see increases well above trend at the next renewal, as well as those that are ASO based will likely see additional increases in aggregate factors. Will plan changes be required? Well, it really depends on what's in the plan now. Lorie was thoroughly pointed out that basically the Coronavirus Response Act and the CARES Act already required testing to be covered without cost sharing. However, there was more of an ability to limit testing to coverage for diagnosis and treatment. So it really depends on what the plan language says. Also the effort to basically place limitations allowed under the mandate is probably going to be something most employers are going to want to include. So the updated guidance does require coverage for testing, even for individuals without symptoms or recent exposure. So if there are limits like that, that will require a plan change. And if you're going to place limitations as the mandate allows, that requires a plan change. If the plan's amended, then the stop loss carrier should be informed and has the right to make adjustments as allowed under the stop loss policy. Thank you for letting me speak with you today and join you in this. I'm going to turn it back over to the Mitigate partners for questions and additional comments.
Hi, Julie.
We'll open it up for Q&A.
Julie, it's Christine Shear. Can you hear me?
Sorry, I hit the video back on, but not the mute. Okay, I hear you.
Thanks. You know, one of the things I'm a consultant, and one of the things I've been working through with my clients, you know, some are insured with both pieces, medical and prescription, under a BUCA carrier, you know, small groups.
Mhm.
And some are, of course, self-funded and some are split. But one of the things we've been working through on the self-funded side, and you talked about this at the beginning of your points, is how we can potentially, you know, what are the ways that we can make estimates of what this is going to cost the plan? Because my guess is that most of us don't have this built into our equivalent premiums this year for self-funded plans. And on the insured side, you know, Lord only knows how much fluff the carriers have built into their premiums for this year. So I'm interested in your thoughts more on the insured side, because we know, like you said, nothing is free. And we've seen that in the comments as well. What do you think the carriers might be looking to dump into their costs for next year, particularly those that aren't experience rated groups, but for those small groups, less than 50, you know, or less than 25, where they're just member level rated, community rated? Any thoughts on that?
Well, you know, the caveat that it's pure speculation, but one of the facets involved in trend and setting trend for all carriers is changes that the government makes and cost shifting from the government. So all increases that are projected by carriers should have something built in already. The big question with this is, because we don't know how available tests are going to be, and we don't know how many members are really going to be interested in self-testing or over-the-counter testing. You know, is that amount that is typically built into a fully insured premium enough or not? And, you know, that's kind of what I was trying to show with the high and the low, anywhere from 2 to 25%. Typically, what we see is that they'll go for extra, that they'll, you know, push it up. If normal increases are anywhere from 10 to 15% on a fully insured program, you know, then maybe you're looking at 20. If the normal increases that you're seeing are more in that 20% range, then you're probably going to see something, you know, 25 to 30. It's kind of like, you know, how whenever there's an oil spill, all the gas prices immediately go up, even before there's any impact. And it's that kind of reaction that, you know, we have a reason here, so we'll make our adjustments because we can talk to them.
So that's helpful. So sort of like, you know, those groups that were renewing in the middle of 2020, you know, in the middle of the first year of the pandemic, where even though the block of business claim experience was down because non-essential services weren't being provided and there wasn't a lot of heavy, you know, COVID claims yet, you know, many of them were still coming out with ridiculously high premium increases. This is again on insured plans,
Right.
Because of the what ifs. And, you know, I guess my thoughts are twofold. You know, one, if a group is large enough, you know, and willing to talk about being self-insured, I think this is another great springboard for them to understand why the control of being self-funded might be really attractive to them. But two, you know, also the importance of all employers understanding that just because you're, you know, a 15 employee group on a member level insured rated plan, don't think for a minute that this isn't going to cost you and your employee.
Right.
Okay, thank you.
Yeah, agree.
Chrissy, can you call out some more questions, please?
I absolutely will. This is actually one from Rich Haney that he just typed in. What do fully insured, kind of keeping on the insured side, what do fully insured employers need to think about as they explore building a fully or partially self-funded program to ensure they're limiting the financial impacts of this new requirement? Best to let the PBM handle the adjudication versus the medical TPA ? I'll let any of the panelists who want to jump into this, feel free, or any of our mitigate partner consultants as well, because many of us are engaged in this regularly.
I can respond and say that was our take, because it was controlled the costs a little stronger on the pharmacy side. If it's, you know, strictly on the TPA side, that mandate at the $12 cap does not come into play. You know, they'll be required to submit, you know, pay if the test is $89. And for clarity, we do see tests out there, $89, $110. So, and if they buy it on the black market, if they buy it on Amazon, you all have seen the price gouging that's happening in the market space. So yeah, it was our opinion that this was an avenue to control those costs better for the client. In our imagination, we can't conceptualize why that somebody would open it up in the reverse because of the lack of controlling costs.
I actually have a self-funded client that they've already been sourcing tests for work purposes for employees, you know, on a very limited use basis, nothing like 8 p.m. That this new mandate requires, but they're talking to their supplier about broadening their access and just direct sourcing them. And again, this is a fully self-funded plan, so they have that flexibility and control to be able to do that, which would them help them control their costs. And I think, Rich, this gets back to your question, you know, how can they mitigate the risk of the financial impact of this?
And I'd like to actually pitch in. There were a couple of questions early, and one popped up during my speech about, it was from a small independent pharmacy about the cost. And I just wanted to clarify that the $12 reimbursement limit, that is not a limit on how much, you know, a pharmacy can sell the test for. That's just the limit on what the plan has to reimburse. And then any excess would be the responsibility of the participant. So, you know, a retailer or a pharmacy can, you know, charge a fair market value price for the test. The question is just how much does the plan pay for it? And if it's not a negotiated arrangement with a group health plan or carrier, then, you know, any charge is only going to be reimbursed at $12 if that group health plan or carrier participates in the safe harbor.
For any of you that need to exit or got other things to do, we will be getting a list of these Q&A and we'll be passing them out with the answers later. But if you want to stay on, as you can see, these panelists, unlike myself, like to talk. So we'll let them keep asking them questions.
There was another question for me about legal chatter on any legal challenge to this mandate. I mean, I have not heard that, but that was my thought too, that I can't believe there won't be, chambers of commerce or groups of employers or, big plans, employers or companies that, don't try to challenge this just because of the potential, for the, the cost. I mean, again, we don't know what the ultimate impact on that will be. So I think, that is a potential. I don't know what kind of grounds we'd have to, you'd have to really think through that, but was it maybe too far an expansion of what was required under the CARES Act and the FSCRA, which, had a component of diagnosis, certainly, this expanded it beyond a medical need to just, employers need to pay for tests. There's no requirement that this be a medical service or a reimbursement of medical care. Employees are allowed to buy these for any, to potentially use in the future when they feel sick. So that's a far cry from what is typically covered under a group health plan. You could almost argue it's not even medical care that's a tax-free reimbursement, but I'm not going to go there on this webinar.
Hey,
but, I think there are some questions about this that could be challenged.
This is from a pharmacist, independent community pharmacist that we nearly and dearly love and are crucial to all of these health plans. This is their question. So whoever feels they can answer it best. We can't purchase tests for $12 at the pharmacy level. Are we in violation of any kind of law or anything if we sell the test for cash and let the patients bill their insurance companies? First question. He said, I've been selling them for $20 and that is only a couple of dollars over my cost. God, I tell you what a mess. We aren't buying them anywhere close to $12 right now. And there's a huge shortage also. The suppliers are running the price up. So again, any thoughts, Catherine? That's probably more in your wheelhouse.
Well, from a legal perspective, that's really Lorie.
I thought I answered that question, Carl. Apparently, I did not answer it. But
no, apparently I wasn't listening. Sorry.
You were not. Okay, because I pulled that one out because that one did pop up when I was speaking. So the $12 is the plan's liability or obligation for reimbursement. It's not any kind of limitation on a pharmacy selling the test. You would be required to post publicly on a website, I suppose, the cost for the test, maybe, but that's not a limit on what you charge. So it's just that you could charge you charge $80 for the test, but a plan, would only have to pay you $12 if you're not in their network and having a negotiated rate with that plan or carrier. So it's again, not a price limitation on the pharmacy.
And it's our interpretation, just to tag on to that there's no limitation to receiving the $12 reimbursement, because so like if you're UNC on that, like the Buy Nextel antigen test was $80 for the two, and they were only going to pay up to $12, which would be the 24. There's no restriction in that we have found that would prohibit you from charging the member the difference between those two costs. So we know it's not ideal. We have heard countlessly that independents can't buy for the same, bulk price that the big box stores are. But if it's any comfort, we have also heard from Walgreens, who absolutely refuses to sell a test for $12, and they want when it's an $8, and we know they're purchasing it like $3 or $4 a piece. They're wanting $20 per test. So, there's others out there who, are not doing the independents any favors in this space either. So it's a pickle for you. We know that.
But to emphasize, I agree with Catherine. There's no prohibition on charging the customer the full price, for that test, and then they get reimbursed what they get reimbursed from their plan. But that's, as my niece would say, not your problem.
Oh, and this is, I'm a huge advocate for the independent. It is their problem because they fight so hard to get customers away from the big box stores and to keep them. And then the services that they do are just invaluable in the communities, so hard. So unfortunately, it isn't.
No,
It is.
Echo that.
Yeah.
But it's just, again, not a
I know,
issue.
legal. I know and everybody's hands are tied. It's horrible. It's horrible.
Mhm.
And just to be clear, what's interesting about this group, most of this group works with independent TPAs, and not as much alongside insurance companies, but there are times we do. And an independent TPA, PBA in Chicago, who we work with in our fair cost plan, they said they were seeing the same things from what we affectionately refer to as the BUCAs. That's Blue Cross, United, Cigna, and Humana. And they're all trying to figure it out, like we all are. So I thought, find that interesting. Does anyone else have any other questions?
There was a question, and of course I just forgot. I was going to ask it. Now I forgot. There was a question a bit ago. Oh, it was my question. Catherine, do you know where we can go to get the list of the states that you were referencing?
I don't think there is an actual list. I know that, let's see, Minnesota is, and it's just kind of the things that are kind of out there that are prohibiting, but I don't know that the government has done a really good way of representing that as a total, because pharmacy law is governed by the state, not by the nation.
Got you.
Uh-huh.
Yep. And then here's one for Lorie that just came through. Can you provide your opinion on who is responsible to pay for the COVID test, the PBM or the insurer? In this situation, Blues plan, and then their independent PBM. So they have an insured Blues plan, and I think separate, probably self-funded PBM, maybe insured, I don't know. But they're pointing fingers at each other. Nobody's taking responsibility. So the employer is sort of caught in the middle.
Oh, absolutely. That is, and I think it's typically when you would have a fully insured plan and a carve out pharmacy, because they're generally, maybe not working well together. A lot of you are more expert on that probably than me, but I don't think there is a good answer to this question, because this requirement really does straddle both medical and pharmacy. So yeah, that's something obviously the law does not address. It doesn't impose it on one side or the other. It imposes it generically on the group health plan. I've mostly been working on this with my self-funded clients. I think that I will actually look at that, and we're going to put out, I think, an FAQ with responses, because I'd like to go back and look a little more closely on how the law applies to the insurance carrier, because it may be drafted in such a way that it does impose the liability on one or the other. Now, Catherine, you may have already evaluated this closely given your involvement and position, but that this is something that where we have clients, it's been important to see coordination and unification between pharmacy and medical. And if they're each pointing a finger at each other, I mean, it's the employer that is absolutely going to lose in that situation.
It is.
Yeah, and it sounds like, oh, sorry, Catherine, go ahead.
No, that's just fine. I can wait.
I was just going to say the individual that asked the question clarified that they're a self-funded plan. So it sounds like they're ASO with a Blues plan, and then have a PBM separate relationship. So in that instance, my take is that it's the plan. You are the plan. The employer generally is the plan sponsor and is the plan. So it ultimately falls to you to make that decision. And so in that situation, what I as a consultant would recommend is, if they're both going to punt on this, which I'm really surprised your PBM is punting, because I haven't seen a PBM yet that hasn't stepped up in one way or another with a solution. Then look at sourcing it directly and cutting them out. And then I would also seriously consider those relationships longer term, because the I also haven't seen a Blues plan yet, and I don't really work regularly with the Blues plan that you are working with, that also doesn't have some level of solution. So not saying
Okay,
that
yeah, I
they're
didn't,
easy, but
I see.
yeah, I didn't see the written question. But yeah, so I'm surprised as well. And, I think it shouldn't be up to the employer to have to do that. But, it seems to me, and I think Catherine, you mentioned this earlier, that it is easier on the pharmacy side to make this adjustment to provide the tests, just given the way that, they should be set up for delivery. But, that's because I think it's going to be a little bit more difficult on the medical side to make it a free at point of sale. But that's just my view.
Agree.
here's another comment that I want to share. I actually know a little bit about this. Just an FYI, our pharmacy ran a test under Optum, and a rejection that came through, it said it had to be dispensed at a Walmart. Crazy. I actually looked at Optum's standards the other day. I have a new client that's insured with United Healthcare using Optum, and they are mandating, if you want it paid for at point of service, that you have to go to Walmart or one other big pharmacy chain. So they've limited to that, and that really is their right based on what I understand with these regulations. Catherine, I don't know if you want.
Catherine, I'll speak to that since I'm a MBM expert. No kidding. Yeah, Chrissy, and Catherine knows this. There's ways to build these programs for employers where you can have preferred and non-preferred pharmacy networks. So absolutely, if you decided, and Catherine, again, you've forgotten more than we'll ever know. If you want to have it dedicated to one pharmacy, you absolutely could do that. Mm-hmm. But you have to educate your members on that.
Well, and it hinges on what we talked about at the very beginning that I said was such a pivotal point to all of this. And it's the key term, adequate access. So what I heard on the Optum side is that they had to do some pretty savvy supplementing to that network because, as you run a geo access, Walmart isn't everywhere. So while they think they are, they're not everywhere and they can't service everyone. So adequate access really became a contention point for them.
They have online. So that's probably another component of it, that you can go online at Walmart, I assume.
Yeah.
That's part of either. Yeah.
Another question too was, we've been asked and clients asked about buying in bulk. And, we have some really smart clients and they were funny. I mean, with supply shortages and things, and just depends on your type of business. Your healthcare business, that's a totally different deal. But, somebody asked the question, what's your advice on buying in bulk? Lorie, Catherine, y'all have any thoughts on that? Doing that up front and then get it to your employees?
To me, that's a different issue, and it's not, I think you can certainly do that. You can give out tests to your employees. That doesn't change your obligation for the group health plan to be able to make those tests free at point of sale. So we kind of separate that a little bit because the question also involves HIPAA. Under HIPAA, employers kind of wear two hats. They're the sponsor of the covered entity, their group health plan, and information they receive from their group health plan, that's HIPAA. Employers can act also in their capacity as an employer. And even though there might be some medical information involved, it's not necessarily HIPAA. Buying bulk tests and passing them out to all employees, that is something we've seen a lot of employers do. That does not involve HIPAA, particularly because there's no, maybe not even if they were asking people, we want you to have it if you think you're sick or if you have symptoms. That would be probably impermissible ADA inquiry. So more than likely, if you're buying in bulk and passing out tests, you're just doing it to give employees these tests and make it available. Under the group health plan mandate that we're talking about, that is a specific requirement to the group health plan, which is a separate legal entity from the employer. So what the employer does with its employer hat is one thing. That's great. You can make those available, but that doesn't limit your liability with respect to this ACA mandate to provide 8 tests per person per month under your plan. You still have to do that too, because that's a requirement to the group health plan. It's really not a requirement of the employer, and that may be a little bit too legalistic. But just bottom line is that would not be a workaround to all of these issues that we're talking about with making this free at point of sale and all of those other concerns that employers have under this test coverage mandate.
Thank you, Chrissy. We got any more questions out there?
I haven't seen any other ones come through. Lorie, can I poke on that answer just a little bit for some clarity? So tell me if I'm wrong here. So my understanding is that in order to qualify for the safe harbor, they need that preferential, that preferred network, if you will, in order to qualify for the safe harbor to limit reimbursements at the $12. Is that a pretty general, accurate statement?
Correct.
And then if an employer didn't care about qualifying for the safe harbor, I shouldn't say the employer, the plan. You know, I'm the employer. I'm wearing my plan hat now, my self-funded plan hat as a covered entity. Could I then, as a plan, buy those tests in bulk as long as I had them as reasonably available as is possible with the supply constraints, and, you know, made available up to 8 p.m. for covered plan members? Would that be okay then?
Well, I think it would be okay, but I think, you know, I think that raises, you know, maybe some technical legal issues. But if you're saying I, the employer, am giving these out versus making it available through my network and my plan at point of sale, I'm not sure that technically you've satisfied the requirement for the plan to make it available. Now,
why not? What do you see there that would preclude that? Oh. If I'm sourcing them as the plan, not as the employer, but as the plan, if I'm sourcing them directly and buying them in bulk and providing them as the plan, and making that my source, and they are as available as they are retail or other, you know, direct ordering.
I mean, are you trying to say, can the employer be the point of sale is really what you're asking?
Yeah,
I mean,
the
that's
employer
what
as the plan. The employer as the plan, wearing their plan hat.
I mean, you know, maybe if the employer is CVS, sure. You know, but the employer, I think, well, one, I mean, I think I guess you could make the argument. I'm not comfortable because it's outside the normal plan. You know, the concept of this is I, as an employee, if I want my privacy, you know, anything I buy under the plan is private, is protected. The employer doesn't know. I mean, and granted, you don't have to have a medical reason to buy your 8 tests per month, but an employer forcing delivery of care at the employer level, I think it does raise a whole host of other issues. I mean, so I think it's just a really bad idea to do that for, you know, just employee privacy concerns of, you know, is there intimidation? I don't even, you know, is the employer, is it reasonable if you don't want to go to your employer and ask for it and the law requires that you make it free at point of sale under the group health plan, which for most employees they view as anonymous? You know, we could get down in the weeds. I would not recommend it.
Okay. Yeah, I see it as being a part of treatment, payment, and operations, TPA, under the health plan, under HIPAA law. So I feel like if a plan, the employer as the plan could, find a reasonable way to not, just make this, not make, a lot of people at the employer becoming aware of this. I don't know. I'm trying to think of creative solutions to mitigate the cost risk.
Yeah.
And make control continue to be a part of the plan while still meeting legal requirements.
Yeah. So the employer itself is not the plan. The plan is a separate legal entity.
Right.
So
when I say employer, I mean plan, employer as plan. Yeah.
But the employer is never the plan. The employer is only the sponsor of the plan. So if the employer is delivering the tests, I mean, they're giving them out free, that's great. But I think that's the employer with its employer hat on. I mean, if they're trying to limit the test they're giving to their group health plan participants, I mean, I understand what you're saying, and I hear you that this is making it easier and better. I think this is an area where no good deed goes unpunished, ultimately, because one, you don't want to get that kind of. I don't think the employer wants to have that kind of PHI. I mean, if they are doing it as they're trying to say, we are a plan provider, we are now your network provider, we're your source for these tests. I mean, that's a role most employers don't undertake unless they are already a healthcare provider. And even then, we generally get uncomfortable, with healthcare providers limiting care to, you run into all kinds of issues that can come back to haunt you on the employment side with discrimination claims, knowledge claims. So it's something we would not, even if it's easy and makes sense and is helpful, I still think it raises too many questions, on a bunch of levels.
Hey, Lorie, and we'll wrap up in a minute. Some senior citizens like myself have to go to the early bird dinner. Quickly, Lorie, address, hospitals. And, you worked with some of our clients that are hospitals. I know the healthcare has to comply and follow this rule, and they're not excluded from it. So talk about that a little bit. I mean, and how I was just curious to your thoughts on the healthcare side.
Well, they're already, I'm sure, built in, as a provider under their plan, but you have systems in place, hopefully, to sort of Chinese wall off your participants who go and receive care, and, how that's processed. I mean, and it is difficult and it does raise more questions, but in my view, it's fine to make your own hospital a provider. Where I become concerned is when it's limited to your own hospital, because then, an employee who has a condition they want to be treated privately for, in order to have it paid under the plan, they're forced to go to their employer for that very sensitive care, and they're receiving it from another employee. And so I think if it's an option, that's great. But I think where it's more problematic is if it's the only option. And some of that's not so much that it violates any ERISA law, but we see on the employment side, knowledge of the employer of an employee's health condition. That knowledge, advanced knowledge, can make it extremely difficult to fire a difficult employee, because the first thing that's going to happen is, well, you knew I had this disorder XYZ. You're just firing me because I'm expensive on your plan. And so you have to be really cautious about getting that kind of information and knowing that kind of information. And I get that, asking for a free COVID test isn't really revealing anything about a condition, but I still, to me, I guess you can argue again, it's point of sale, but I think it's just better to have it operate under the normal channel and not have the employer get in the business of being a point of care or a point of distribution, you know, as if they were a pharmacy or a retail, just because of the potential arguments later that might come up from an employee.
One of all our mutual clients, you know, in some of the hospitals we worked with in the past, that's exact. Some of them have in-house pharmacies. So yeah, they had to, through conversation with Catherine and her team, they've had to open up, you know, the network to others because of supply.
Mhm.
So it's kind of a moot point in a way, I think.
Right. Yeah, probably so.
And the only other thing I would add to that discussion is, you know, typically, I've been in this space for 35 years. Typically, point of sale is transactional, and I sit on, you know, I sit on several committees in NCPDP. I've been a longstanding NCPDP member. Typically, from what we know, is point of sale does have an electronic transactional component to it. So, you know, unless that element is there, I don't know that it would be strongly arguable that point of sale is not electronic.
Yeah. I mean, I think that's a big point is, you know, I think the employer can give them out, but if the employer is giving them out, I see that as a broader employer initiative of under like OSHA of ensuring employee safety. And that is something that OSHA may look to an employer to say, you want to keep your people safe. They should be getting vaccinated. You should be giving out tests, but that's a completely different set of laws than on the other flip side, this FAQ mandating group health plans pay for tests at the point of service.
Yeah, totally agree.
Thank all our panelists for being here and all the people that attended. If you have questions, you could go back to and send them to contact at mitigatepartners.com, or like I said, post them here and we'll get back to you with it. And we will send some printed copy of the slides out in a couple of days. And we appreciate everybody being here. And, you know, you can also rely on the U.S. Postal Service. And unless you have the mailman on your team, like Stetson Bennett for the Bulldogs, it's hard for, you know, I don't know how well they'll deliver. But anyway, thanks for everybody's time. Have a great day.
Thank you so much.
Have a great day.
Thank you.
Thanks. Bye.